Hello everyone. Today we will discuss about the pulmonary artery hypertension. So, like introduction part, pulmonary artery hypertension (PH) is a progressive disease. This is a progressive disease of the pulmonary vasculature, which result in right heart failure and excess morbidity and mortality without effective treatment. Like effective treatment is not available for pulmonary artery hypertension. It can lead to morbidity and mortality, and true reversal is not possible at all. Long delays in the diagnosis is common and exposing patient to prolonged suffering and potentially irreversibly harmful for them. So pulmonary artery hypertension should not be confused with other mechanisms leading to elevation of pulmonary artery pressure like hypoxemic lung disorder like COPD or ILD or left heart disease. It could be systolic, diastolic or valvular dysfunctions or chronic thromboembolism. So we should not confuse with these conditions which can also lead to increase in pulmonary artery pressure. Now we'll come to pulmonary artery hypertension. Like what is the definition? So it is like sclerosis of the pulmonary arteries without identifiable cause. So this is the sclerosis of the pulmonary arteries without the identifiable cause. A hypertensive vasculopathy of pulmonary circulation involving vasoconstriction, increase of pulmonary artery pressure, and a measurable response to the injection of non-selective alpha-adrenergic antagonist like tolazolene. So when we will give a vasodilator, it will create like vasodilation, and it is there is increase in pulmonary artery pressure. So no cause we identified for the pulmonary arteriopathy, and the term primary pulmonary artery hypertension was introduced. So what is like idiopathic pulmonary hypertension, which was initially we used. So they are telling like abandonment of the term primary also is important as means of discouraging the use of confusing and clinically inappropriate term secondary pulmonary hypertension. So now we use only idiopathic, not primary or secondary terms. Use of such primary and secondary grouping may inappropriately suggest clinical similarity among the many very different conditions previously referred to as secondary pulmonary hypertension, patient with COPD and those with congenital heart disease. So we should not categorize these group according to primary or secondary. We should like divide them accordingly like idiopathic pulmonary hypertension. So what is the updated classification of pulmonary hypertension? This is like very important classification. So it used to divide pulmonary hypertension into 5 parts. First is pulmonary artery hypertension. It could be idiopathic pulmonary artery hypertension. It could be heritable pulmonary artery hypertension, drugs and toxin induced associated with connective tissue disease, HIV infection, portal hypertension, congenital heart disease, schistosomiasis, PH long-term responder to calcium channel blockers, or pulmonary artery hypertension with overt feature of venous capillary involvement. Persistent pulmonary hypertension of the newborn syndrome. So these all conditions come in pulmonary artery hypertension. So this is class 1 of pulmonary hypertension. So what is the class 2? Class 2 is like pulmonary hypertension due to left heart disease. So pulmonary hypertension due to heart failure with preserved left ventricular ejection fraction, or it could be due to associated with reduced left ventricular ejection fraction, or it could be associated with valvular heart disease or congenital or acquired cardiovascular conditions leading to post-capillary pulmonary hypertension. So these are like due to left heart disease. So category 2 is associated with left heart disease. Now comes category 3, which is pulmonary hypertension due to lung diseases and or related to hypoxia like obstructive pulmonary disease, restrictive lung disease, other pulmonary disease with mixed restrictive and obstructive pattern, hypoxia without lung disease or developmental lung disorders. So these lung conditions comes in category 3. Now comes category 4. Category 4 is pulmonary hypertension due to pulmonary artery obstruction. So obstruction could be because of a lot of conditions like chronic thromboembolism, other pulmonary artery obstruction like sarcomas, high or intermediate grade, or angiosarcomas, other malignant tumors like renal sarcoma, carcinoma, uterine carcinoma, germ cell tumor of testis. These can also lead to pulmonary artery obstruction. Non-malignant tumor like uterine leiomyoma, arteritis without connective tissue disease, congenital pulmonary artery stenosis, or parasites like hydatidosis. So hydrated disease can also lead to obstruction of pulmonary artery and lead to class 4 of pulmonary artery hypertension. Now comes class 5, pulmonary hypertension with unclear or multifactorial mechanism. So in this condition comes like hematological disorder like chronic hemolytic anemia or myeloproliferative disorders, or it could be due to systemic and metabolic disorders like sarcoidosis, pulmonary Langerhans histiocytosis, Gaucher disease, glycogen storage disease, neurofibromatosis, like that. So all systemic and metabolic disorders comes in category 5, very important. And other conditions like chronic renal failure without or with or without hemodialysis, fibrosis, mediastinitis, or complex congenital heart disease. So like if we will see grossly, so category 1 is due to pulmonary artery hypertension Category 2 is due to left heart disease. Category 3 is due to lung diseases and hypoxia related. Category 4 is due to related to obstruction, pulmonary artery obstruction, and category 4 is because of multifactorial causes or unclear causes. So these are the 5 classes of pulmonary hypertension. Now we'll come to determinants of pulmonary artery pressure and pulmonary vascular resistance. So they are telling like the pulmonary circulation normally is a high flow and low resistance and low pressure system that carries blood into the pulmonary microcirculation where the blood takes up oxygen and unload the excess carbon dioxide. So here blood used to take oxygen from lungs and remove the excess carbon dioxide. Now pulmonary artery pressure is the product of cardiac output and pulmonary vascular resistance, where pulmonary vascular resistance is the vascular resistance of the entire lung, including the pulmonary artery or capillary or vein. So in vascular, artery, capillary or vein comes. So they are telling pulmonary artery pressure is cardiac output into resistance of all these blood vessels. So during period of increased cardiac output like strenuous exercise, it lead to significant increase in pulmonary artery pressure. Okay, so but in the normal healthy individual, the pulmonary artery pressure is slightly increased during slightly increased, not like significant increase, only slightly increased, because due to increased cardiac output will lead to compensation by the increase in the cross-sectional area of the pulmonary vascular bed due to recruitment of previously unperfused vessel used to get recruit, and there is distension of vessels. So like the pulmonary vascular resistance in these blood vessels used to decrease, cardiac output used to increase, but because of this resistance decrease, pulmonary artery pressure is approximately like little bit increase, not like there is not significant increase in the pulmonary artery pressure. So they are telling arterial distension and optimal recruitment are dependent upon the compliance of the blood vessel wall. Loss of this compliance and recruitability due to vascular remodeling lead to pulmonary hypertension. So this compliance used to get lost in the patient of pulmonary artery hypertension. Now they are telling like even a small change in the radius of a vessel can significantly change the pulmonary vascular resistance, because pulmonary vascular resistance is directly proportional to 1 by r ki power 4. So it used to depend, if there is a small change in radius, then it can lead to like a significant decrease in pulmonary vascular resistance. Now I'll come to functional and structural changes in the pulmonary artery hypertension. So there are a lot of mechanisms are there. First mechanism is increase in cytosolic calcium. So this increased cytosolic calcium and increased calcium sensitization can lead to smooth muscle contraction, which lead to sustained vasoconstriction and finally lead to pulmonary artery hypertension. Now there are other various mechanisms are there like increased fibroblast growth, increased transdifferentiation, which lead to advential hypertrophy, increased PASMC and proliferation, and decreased PASMC apoptosis can lead to medial hypertrophy, and increased PAEC proliferation and increased PASMC and PAEC migration can lead to intimal hypertrophy, which can finally lead to vascular remodeling. Then comes platelet fibrin PAEC, which can lead to coagulation and fibrotic clot formation that finally lead to in situ thrombosis. And there comes like increase in collagen and tenacin C, which is very important. We have to remember this thing like tenacin C. So increase in tenacin C can lead to increased extracellular matrix, which finally lead to increased arterial wall stiffness. And these all things finally lead to increase in pulmonary vascular resistance and increase in pulmonary artery pressure, and and finally they leads to like pulmonary arterial hypertension. Very, very important. Now what are the structural changes? So here we can see there are 3 arteries. First one is like normal blood vessel. Hypertrophy of smooth muscle is seen in the pulmonary artery of a patient with pulmonary arterial hypertension. So here we can see this thing is like hypertrophy of smooth muscle layer. So and this like third image shows like extension of muscle into normal non-muscularized small intra-acinar pulmonary vessels is another prominent feature of pulmonary arterial hypertension. Here we can see these small protrusion of these like muscles into the non-muscularized part of blood vessel. So this is also like very important feature of pulmonary arterial hypertension. Here you can see like 4 diagrams of heart. This is the normal heart. This is the hypertrophied right heart. Here you can see this is the hypertrophied right heart, which is seen in pulmonary arterial hypertension. Here we can see like a cut section of the right heart, which is showing like very thin right ventricular wall. But here this thickness used to get increased, and also there is a dilatation of right ventricle. So hypertrophy and dilatation of right ventricle is seen in pulmonary artery hypertension. So now we come to like what are the other mechanisms which lead to pulmonary artery hypertension. First thing is sustained vasoconstriction. So here we can here they are telling like pulmonary vasoconstriction is major contributor to increase pulmonary vascular resistance and which lead to increase in pulmonary artery pressure. Vasoconstrictive lesion include medial hypertrophy. So tunica media layer will get hypertrophied, involving an increase in the number and size of the pulmonary artery smooth muscle cells. Other thing is like elevated pulmonary artery pressure and sustained vasoconstriction in pulmonary artery hypertension lead to enhanced pulmonary artery smooth muscle cell hypertrophy and hyperplasia. There, marked smooth muscle cell hypertrophy can eventually cause medial atrophy, fibrosis, and subsequent thinning of the media and dilatation of the vessel lumen. Extension of pulmonary arterial smooth muscle cells into the vessel, which we have seen in this picture. Here we can see this is the extension of smooth muscle cells layer. So they are telling extension of pulmonary arterial smooth muscle cells into vessel normally only partially muscularized or non-muscularized is common and often prominent feature of pre-capillary vessels. Very important, which is seen in this like pulmonary artery hypertension. Hypoxic pulmonary vasoconstriction is an adaptive mechanism important for redirecting blood flow away from the poorly ventilated area to the lung, which is better ventilated, to optimize ventilation perfusing matching and maximize the oxygen saturation. So they are telling like this is like normal mechanism, but they are telling like hypoxic pulmonary vasoconstriction is an intrinsic property of pulmonary arterial smooth muscle cells. In the condition of chronic hypoxia, two factors contribute to increase PAP, which are like vascular remodeling due to pulmonary arterial smooth muscle cell proliferation and sustained vasoconstriction, and structural changes that develop within a matter of weeks. Like they can develop within weeks. They do not take years. This remodeling is characterized by thinning of the media of the small pulmonary arteries and arterioles and by peripheral extension of muscle into minute pulmonary vessels that are normally devoid of muscles. So here muscle cells will grow. Now they are telling what is vascular remodeling. The thickness and tissue mass of the pulmonary arterial wall are maintained at an appropriate level by the fine balance between proliferation and apoptosis of the fibroblast of pulmonary arterial smooth muscle cell and pulmonary arterial smooth muscle cell and pulmonary arterial endothelial cells. Thinning of the vessel wall and luminal narrowing. Thinning of vessel wall and luminal narrowing and eventual obliteration can occur if the balance is in the favor of cellular proliferation. Like cellular proliferation is more and like degeneration is less, which lead to luminal narrowing finally and obliteration. They are telling resting cytosolic calcium is increased in proliferating pulmonary artery smooth muscles compared with growth arrested cells, demonstrating a role in enhanced calcium in both proliferation and vasoconstriction. In addition to increased proliferation, decreased apoptosis has also implemented in the development and maintenance of severe pulmonary artery hypertension. Hypoxia can induce proliferation of pulmonary arterial advential fibroblast and pulmonary hypertension. And in pulmonary hypertension patients, hypoxia induces the appearance of alpha smooth muscle actin in the proliferative and matrix producing fibroblast. So this alpha smooth muscle actin is very important, and which suggests that these cells have differentiated into myofibroblast. So these like smooth muscle cell used to get converted into myofibroblast in the patient of pulmonary artery hypertension, and fibroblast plays important role in vascular remodeling due to hypoxia. Now they are telling, although not pathognomic, the plexiform lesion has been the focus of many studies of the cellular and molecular pathogenesis of pulmonary artery hypertension. What are the plexiform lesion? They contain, these plexiform lesions are collection of proliferating endothelial and smooth muscle cells together with myofibroblast and matrix protein that can partially or completely occlude the vessel lumen. Narrowing or complete obliteration of the parent vessel by intimal thickening is frequently associated finding as of destruction of its media. So plexiform lesion often coexist with other obliterative vascular changes such as concentric laminar intimal thickening could be there. So like finally these are like collection of proliferating endothelial smooth muscle cell myofibroblast and matrix protein which finally occlude the vessel lumen. So endothelial cells isolated from plexiform lesion of idiopathic pulmonary artery hypertension patient proliferate in a monoclonal fashion, and plexiform lesion from the patient of pulmonary artery hypertension other than eye patch, they are telling like in the patient of idiopathic pulmonary artery hypertension, these cells used to grow in monoclonal fashion, while in other causes of like pulmonary artery hypertension, these plexiform lesion used to grow in polygonal fashion, suggesting that different mechanisms contribute to plexiform lesion development in different forms of pulmonary artery hypertension. Now we'll come to in situ thrombosis, monoclonal proliferation of pulmonary arterial endothelial cells, pulmonary artery smooth muscle cell migration and accumulation of circulating inflammatory cells, platelets, progenitor cells, which result to occlusion of smaller vessels. Thrombosis is frequently seen within the small vessel of patient of PH. This occurs without evidence of embolic source of the thrombus. Like there is no source of thrombus, but these are like small embolic or thrombosis will be there, suggesting a local imbalance of pro and anticoagulant forces, activation and altered function of endothelial cells leading to a shift from anti to procoagulant activities. Like procoagulant activity used to get increased in these patients, might be due to effect of severe stress associated with elevated pressure, because like we know pressure used to get increased. In addition to altered endothelial cell activity, platelet also promote thrombus formation will be there by releasing vasoactive and mitogenic factors such as thromboxane metabolite and serotonin. These as well as other platelet-derived growth factors, products like PDGF, TGF, beta, VEGF also contribute to the remodeling of vessel wall in pulmonary artery hypertension patient. Now there is other entity like increased arterial wall stiffness. So stiffness of arterial wall used to get increased in this patient. They are telling like increased arterial wall stiffness. Increased arterial wall stiffness lead to increase in pulmonary vascular resistance. So they are telling that normal turnover of extracellular matrix protein increases with remodeling of vasculature in pulmonary artery hypertension patient. The expression of tenascin C increase in experimental pulmonary hypertension induced by the either monocrotaline in rats or increased blood flow in the swine. Indeed, the inhibition of tenascin C expression by antisense RNA ameliorate monocrotaline induced pulmonary vascular lesions. So they are telling like the expression of tenascin C used to increase pulmonary artery hypertension, okay, by the help of monocrotaline. Elevated level of extracellular matrix protein are seen in pulmonary artery in the patient of PH. Decreased vascular compliance resulting in the inability to recruit previously unperfused vessels due to increased parenchymal stiffness can also contribute to development of PH. So now there are very different mechanism of pulmonary hypertension, pathogenetic mechanisms. So first mechanism is passive mechanism. So like mitral stenosis, left atrial myxoma, fibrosing mediastinitis, pulmonary vaso-occlusive, veno-occlusive diseases. These all things can lead to pulmonary venous hypertension, very important. Then comes hyperkinetic. So they are telling like in hyperkinetic conditions, there used to be left to right intracardiac shunt used to get formed, which lead to increased pulmonary blood flow. Then comes obstructive mechanism. High grade obstruction of large pulmonary arteries by organized thromboemboli or multiple pulmonary emboli leads to thromboembolic pulmonary vascular diseases. Then comes proliferative causes, obliterative causes. So interstitial lung disease, pulmonary artery hypertension and schistosomiasis lead to inflammatory or proliferative pulmonary vascular disease. Now comes venoconstrictive diseases like venoconstrictive conditions like high altitude, chronic bronchitis and emphysema lead to hypoxia. So they used to cause venoconstriction lead to pulmonary artery hypertension. Then comes idiopathic causes like drug-associated pulmonary artery hypertension, portopulmonary hypertension or HIV infection. So here like mechanism is unknown. Now comes like decrease of vasoactive substance in like pulmonary vasculature. Deficiency in the production of potent vasodilator like nitric oxide and prostacyclin is observed. And indeed both substances used as a basis of effective therapy. So now in the management part we will discuss like these are the basis of effective therapy for pulmonary artery hypertension. What are these vasodilators like nitric oxide and prostacyclin? So they are telling normally produced by vascular endothelial cells, as you know. Each promote the formation of CGMP or CAMP, which used to cause the relaxation of pulmonary arteries and vasodilation of pulmonary arteries. In addition, both prostacyclin and nitric oxide inhibit pulmonary arterial smooth muscle cell proliferation and platelet aggregation. So in patient with PH, the chronic administration of prostacyclin analog improves hemodynamic exercise capacity and survival. So finally, they used to improve overall survival in the patient of PH. Now they are telling VIP also promote vasodilation and inhibits smooth muscle proliferation and platelet aggregation. So VIP levels are reduced in patient of PH. Acute effect of inhaled VIP was confirmed in subsequent study that included patient with multiple etiology of pulmonary hypertension, including eye patch, congenital heart disease, CTPH, and pulmonary hypertension related to parenchymal lung disease. So like they are telling acute effect of inhaled VIP is also observed. Subcutaneous sustained release VIP analog is being investigated to treatment of PH. So they are telling like these nitric oxide, prostacyclin, VIP, these are like very important part of this pathogenesis of PH, and these form the basis of effective therapy in PH. Now we'll come to increase of vasoconstrictor. So as we know, like decrease of vasoactive substance is there, and like there's also increase of vasoconstrictors. So vasoconstrictors used to get increased. So in vasoconstrictors, first thing is like thromboxane. Thromboxane is a arachidonic acid metabolite which is produced by the endothelial cells and platelets, causes vasoconstriction and platelet aggregation, and is smooth muscle mitogen. So it used to increase smooth muscle cells. Increased thromboxane metabolite have been documented in the urine of the patient with PH. So the metabolite of thromboxane are there in urine of PH patient because they used to get increased. Attention was focused on the effect of serotonin on the pulmonary circulation by the epidemic of PH in patient of who ingested the appetite suppressant like aminorex and fenfluramine. Like they are telling, aminorex and fenfluramine. These are the appetite suppressant which used to increase the level of serotonin, and serotonin is act as vasoconstrictor. So these appetite suppressant used to lead pulmonary artery hypertension. These agents increase plasma 5-HT levels by inducing release of 5-HT from the platelet and interfering with its reuptake. So finally, 5-HT causes vasoconstriction in a smooth muscle cell mitogen. A key regulator of 5-HT action is 5-HT transporter. 5-HT transporter whose expression is increased above normal in platelet and pulmonary artery of the patient with eye patch. The overexpression of 5-HTT transporter gene in recombinant mice result in worsened hypoxia-induced pulmonary hypertension. Now comes, so like first thing is thromboxane, second thing is serotonin or 5-HT, and third thing is endothelin. Endothelin 1 is the most potent, very, very important. So endothelin 1 is the most potent endogenous vasoconstrictor yet discovered. Very, very important. Endothelin 1 is the most potent endogenous vasoconstrictor. So it increases in pH and correlate with disease activity also. So it also correlate with the disease severity. Endothelin 1 bind to endothelin receptor A and B. So there are two receptors for endothelin. So they are telling receptor on the surface of pulmonary artery, smooth muscle cell, which causes vasoconstriction. In contrast, endothelin B receptors on pulmonary arterial endothelial cells increasing the production of nitric oxide, resulting in vasodilation. So they are telling like endothelin B receptor can also cause vasodilation. Endothelin B receptor are also active in clearance of the endothelin. The net effect of endothelin's vasoconstriction or vasodilation may be both site and context dependent. So it depends on like what is the condition. As both the distribution and relative expression of ETA and ETB receptor differ according to vessel location in the normal lung tissue and are altered in the patient of IPH patient. Indeed, both selective endothelin A and dual endothelin A or B inhibition improve the hemodynamic derangement and clinical outcome in the patient of PH. So they are telling either we used to selectively suppress endothelin receptor A, which used to cause vasoconstriction. So if we will inhibit endothelin receptor A, then it will cause vasodilation, or we combinedly inhibit, if we will combinedly inhibit endothelin A and B, then also it will cause vasodilation. So now we'll come to increase of growth factors. So growth factors that promote the maturation and stabilization of developing vasculature, elevation in the angiopoietin 1 and its ligand Tie2 correlate with disease severity in patient with multiple form of PH. Angiopoietin 1 regulate pulmonary arterial smooth muscle cell hyperplasia in PH. Very, very important. So angiopoietin 1 is an important growth factor here. Another modulator of development is like VEGF, and its target tyrosine kinase receptor are increased in pulmonary vasculature of patient of PH. Increased VEGF expression has been reportedly specifically within the plexiform region. A lot of VEGF are there in plexiform regions. Then comes the like elevation in angiopoietin increases in the expression of VEGF. So they increase expression of each other. Now comes PDGF. PDGF has been implemented in smooth muscle cell proliferation migration, which is thought to contribute in PH pathogenesis. The tyrosine kinase inhibitor imatinib has a particular affinity for the PDGF receptor, and several small studies have identified a potential benefit in the PH patient. So by the inhibition of PDGF by imatinib, it used to block PDGF, it causes benefit for PH patient. So this is like IMPRESS study. But serious adverse event, including multiple cases of subdural hematoma, has been observed. That's why this like imatinib therapy is not approved for PH patient. Very, very important. So imatinib used to cause subdural hematoma in patient of PH. So that's why it is not used or approved. There is another thing which is known as microparticles, represent vesicle fragment of the cell membrane containing various proteins and antigens that are involved in cellular communication. These small particles are released during cell activation and apoptosis and can be derived from multiple cell lines, including endothelial cells, platelet, leukocytes, red blood cells, and fibroblasts. So they are telling like circulating level of these endothelial microparticles used to get increase in PH patient. So these are also a important thing, like these microparticles used to get increase in the patient of PH. They're telling there is also increase in cytokines and inflammatory markers. The close association of systemic inflammatory disorder to IPH has implicated inflammation as an important factor in vascular remodeling. Tumor necrosis factor alpha and tumor necrosis factor alpha and interleukin 1V, 2, 4, 6, 8, and 12. These are also associated with pH. Increased level of interleukin 1 beta and interleukin 6 in IPH patients, and higher IL-6 levels were later to be found associated with mortality. So these interleukins, and there is chemokine fractline CX3CL1 is elevated in CD4 cells and CD8 cells of PH patient. And further studies have shown that CX3CL1 may promote proliferation in pulmonary arterial smooth muscle cells. So this is also important regulator. Then comes monocyte chemotactant protein MCP1 is also elevated in serum and lung samples from IPH patient and may influence monocyte and T cell recruitment in disease. So MCP1, chemokine fractline, CX3CL1, increased level of IL-1 beta and IL-6, and interleukin 1, 2, 1B, 2, 4, 6, 8, 10, 12, P70. So these are important factors. Then comes increased expression of regulated upon activation normal T cell expressed and secreted. So RANTES has been found in lung samples from PH patient as a chemotractant for monocytes and T cells. RANTES is thought to promote inflammation, but also play a role in synthesis of endothelin 1 and causes can act as potent vasoconstrictor. So these are the mechanism. Here we can see this is like bone morphogenic protein which used to act on BMP1 receptor and BMP receptor 2. Here there are like voltage gated potassium channels. These are voltage gated calcium channels. These are like different mechanisms of pathogenesis of this pulmonary artery hypertension. Here we can see like finally it used to lead to increase in cytosolic calcium level. So here we can see this is like serotonin receptor, Rho receptor, Rho A or ROC signaling, MAPK signaling. So finally these all things lead to decrease in the level of mitogenic activated protein kinase and like increase PA-SMC proliferation and increase in PA-SMC contraction. So